This is, I guess you can see that. Lung cancer screening. I looked at this slide this morning and I thought, 10 easy steps. It sounds like Alcoholics Anonymous. They have the steps. Anyway, I'll try to move through the slides pretty quickly because this tends to be kind of a politically charged subject. I used to think it was the most politically charged, but Obamacare really gets all the headlines now compared to cancer screening. But anyway, that was great, that last talk. I think the surgical techniques, the surgical results are fantastic now, and the challenge ahead of us is finding the patients for Dr. Mazur, because we've all seen the opposite of the patient who shows up in the emergency room and is inoperable. And unfortunately, that's usually the case. So we're going to talk about how we can change that a little bit. Is that right? Okay, so number one. I got it. Oh, I think. Okay, good. Is this an important health problem? I think that kind of goes without saying. I talked to my wife Jennifer this morning, and it's homecoming at Carlsbad High, and the reason I mention that is because from time to time I go by Carlsbad High and I see kids out there lighting up cigarettes, and you're thinking, they have health ed, and yet this problem is not going away. The smoking rates are still there, the lung cancer rates are still there, so obviously this is an important health problem. Just a couple of numbers to confirm that. And I think that's an underestimate, 158,000 deaths, but it's in the ballpark. I think it was more like 178, but anyway, you get the picture. A lot of people are dying. So, number two. This is very important. You would think it goes without saying, but we've learned those lessons the hard way, that this is not necessarily a true statement. We've all discussed prostate cancer screening, breast cancer screening, and both of those modalities are confounded by discovering cancers that the patient would not have died of. So this is a big issue in cancer screening in general, although in lung cancer, I think what data we have is pretty good, that there's really a consensus that screening is valuable if you can diagnose the cancer early enough, because the natural history of the disease is so bad that generally the patient more than likely will die of it if left undetected or untreated. So of course the answer to that, we're thinking, is yes. And this kind of makes that same point. Stage 1 versus stage 4. That is a terrible statistic. Stage 4, 5-year survival, 1%. But sadly, that's not only is it accurate, but it hasn't changed all that much in the past few years. The things that I can do for patients with stage 4 cancer are fairly limited. And that number may be creeping up to 2 or 3%, but it's not going to be 25% anytime soon without some major changes in treatment. So obviously, the key battle here is to find those stage 1 patients so they can have that surgery that we just saw. So are facilities available? Obviously they are. We'll talk a little bit in a while about the CAT scan screening, and I think in our community there are 3 CAT scanners that meet the criteria for screening, which is a helical, low dose, very thin slice. Any radiologists here? No? I can say anything I want then. Okay, but anyway, we do have 3 scanners in the community that can be used for screening. And I'll talk a little bit about cost later. Is there a recognizable asymptomatic stage? Obviously, again, the answer is yes. We really don't need a randomized study to prove that. Anybody in primary care will tell you they've had a patient walk in, have a chest x-ray, or a pulmonologist will tell you patient had a CAT scan for some other reason, and there's the lung cancer, which is not symptomatic. is there a suitable test for screening? A much more difficult question to answer than the last question. The reason being that prior attempts were failures. There were a number of studies done in the 70s, I think on the next slide. Yeah, there were chest x-ray studies done that were failures in terms of trying to screen. There were sputum cytology studies that were failures. And up until recently, maybe the last 10 years, the attitude was that there's nothing really we can do other than smoking prevention programs and try to improve treatment. But in the last 10 years, we have found that the CT scanning screening is effective. So the answer is yes. I think everybody can see the little nodule there at the base of the right lung. That's actually not what we're looking for on screening, even though, all right, there's the little nodule, of course, but that's not what we're looking for. That's big for a screening CT. This is the kind of thing you would pick up when somebody walks in the door for their first screening. But what we're really hoping for is to find nodules before they get that big. This turned out to be a cancer. It also turned out not to be visible on the patient's chest x-ray. So anyway, I'll talk a little bit about the National Lung Cancer Study and the Canadian study. I'll get to a couple of slides and we'll go over that. Is the test acceptable to the target population? Once again, just ask a gastroenterologist how important this question is. We have a great screening test for colon cancer, but we don't necessarily have great compliance because the test is not all that acceptable to the population. And people really don't want to drink 4 gallons of Go Lightly and everything else they have to do for a colonoscopy. So we needed a test that is easy to do and that people are willing to have done. So I think we have that test. All these things are true. You don't have to undress. You don't have to get in the stirrups. You don't have to drink anything. There's no IV injections, no barium. And I asked Bill Johnson how long one of these took, and I was shocked. He said, well, we can get them scanned in 4 minutes. Get on the table, zip, 4 minutes, you're off the table, you feel nothing, and you're done. So this is an acceptable test to the patients. And that is a big hurdle because some of our other screening tests are really not all that acceptable. So moving right along to number 7, do we understand the natural history of the disease? This has become a big issue because of the problems we've run into with prostate cancer screening, where we don't have very good patient selection. We have the patients deciding rather than the physician deciding whether or not they get screened, and then we detect cancers that the patients weren't necessarily going to die of. We're also running into this with breast cancer because of MRI images rather than mammogram images. MRI images are much more detailed, detecting tiny, non-invasive cancers that the patient, the doctor, the surgeon then feel obligated to do something about. And we really don't have any good data or randomized trials that ever would have been a fatal illness. So it has become very important in other situations to understand the natural history of the disease. With lung cancer, it's maybe a little bit easier. Anyway, I touched on breast cancer. We do have some data, not great data, that early detection is beneficial. There are things we can't do to prove that. For example, we can't ask half of a population of women not to have mammograms, which is really the only way you can prove that the mammogram saves lives. And it's really such a politically charged issue, patient-directed or physician-directed, that randomized trials in some of these situations are now impossible. So all we have is retrospective looks at, well, how many people used to die of breast cancer before we had mammograms, and now how many people are dying of breast cancer? That's not all that valid because during that period of time, treatment improves. So it's very difficult to really put numbers on some of the other screening tests and look at how many lives are being saved. And it can be a difficult issue, but with lung cancer, it's not all that difficult because the mortality of the illness is terrible, as we saw, and the treatment is clearly better for early disease. So where are we up to? The natural history of lung cancer. Look at the small number of patients in this particular study that I quoted, 39 patients. Well, when you think about it, how do you do this study? It's not like you can ask patients, well, you've got lung cancer, but we'd like to observe your case and see how long you might live. So very difficult data to get, but obviously these short survivals indicate the need for treatment. So number 8, is there a policy on who to treat? Generally, that's kind of goes without saying because we look at the natural history, we see the high mortality. Anyone who is fit for screening is fit for treatment. Now, we're working on that. That's a little bit touchy because if you let patients self-refer, like you do with PSAs, I know we have primary care doctors here, and patient comes in, he wants a PSA. Well, you have two choices. You can spend 15 minutes talking to the patient, explaining that really at 80 years old, you know, even if it's elevated, we're not going to treat you anyway. Or you can spend 30 seconds just checking a box that says PSA on the lab slip and, oh, sure, you know. It's just human nature, you know, over and over to give that same 15-minute speech. Dr. Barron is smiling at me because we know he's been there and done that. That, you know, do you really want to go into this 20-minute argument with the patient explaining why he doesn't need a PSA? Just get the PSA. Hopefully it will be normal and it won't matter anyway. But that is the reality of taking care of people. So anyway, we have to look at that with lung cancer. If someone comes in with an oxygen tank and, like Dr. Mazur said, they failed the test of walking up to his office because they only can go up 3 steps, then you have to try and talk this person out of lung cancer screening because they're not fit for treatment anyway. And it's a little bit tricky, but if we can do that and focus on the right patients, then we have a good policy on who to treat because we've already eliminated the people that aren't going to be treated and we've just screened the people who are fit. So number 9, is it economically feasible? This has been a sore issue also, but the price of CAT scanners CAT scans has come down dramatically over the past few years. So, and these scans don't require a prep, they don't require IV contrast, and they're quick. And so the prices have come down to the point that this is starting to get competitive with mammograms to screen patients.
How much is it? I think
As little as $100. I thought you would ask that. As little as $100. Now, what comes up? Trust me, I'm a doctor. They're going to be cheap. Well, I'll kind of touch on that at the end. I can't speak for Tri-City or IHS or the others and say, oh, I know it's going to be $100. But if you wander around the country, you will see newspaper ads for chest CTs $99. They are out there. And one of the issues that comes up is that's a very minimal cost, but 1/4 of the patients require follow-up. So you look at that and say, wow, that's like having mammograms. It hardly costs anything. But most mammograms are negative. And when you look at the screening population for lung cancer, these are heavy smokers, the lungs are abnormal. 25% of the scans are abnormal in some way. So then follow-up scans have to be done at certain intervals, and so you end up with a much higher cost to actually do the proper screening, but not necessarily the patient paying, because if you do the first scan, the patient may decide, well, I'm going to pay $100 to get lung cancer screening. So they go in, they get the screening, they have to pay. The radiologist says, well, there's a 3-millimeter nodule in the right middle lobe, recommend 3-month follow-up. Well, now the patient goes back to his primary care doctor, gives him this thing and says, I might have lung cancer, I need another CAT scan in 3 months. At that point, whatever the insurance is will probably be forced to cover it because it's not screening anymore. It's follow-up on a pulmonary nodule. So regardless of whether the Obamacare is repealed or not, I think this is going to continue and not be a huge out-of-pocket expense for the patients, just that initial scan. If the law is not appealed, there's some provisions in there that kind of force insurance companies to pay for preventive health care. So it may be that this will be covered anyway, but we'll see. So looking at some of these numbers here, they're a little bit shocking. When you look at the National Lung Cancer Screening Trial, they felt that they prevented 6.2 deaths by screening 10,000 people for a year, or 5,000 people for 2 years, whatever. And when the Canadians, who also participated in this trial, kind of backed up and looked at their mammogram results, they decided that lung cancer screening was more effective than mammogram screening. Now those numbers vary from country to country and how you interpret all these statistics. The Swedish study, they felt that mammograms were much better and comparable to CAT scan screening for lung cancer. So I put both of those up there. So obviously, yes, this is an ongoing process. You can't simply have people walk in the door, get a test, and follow them. Never. They really, with 25% of the scans being abnormal, the follow-up is crucial, because what happens with the screening is you get these tiny nodules that are 2 millimeters, 3 millimeters. The surgeon says, I won't remove that. I don't know if it's cancer. The radiologist says it's too small to biopsy. The nuclear medicine doctor says it's too small for a PET scan. So really your only option is to have the patient come back in 3 months, or whatever interval you've determined is appropriate, and rescan them to see if it gets any bigger. So if there's no ongoing follow-up, the yield on scanning becomes very poor. It's really critical that patients know you have to come back. At least 1/4 of the patients have to come back. So these were the results. I think I touched on this in the other. Oh, I'm sorry. There's kind of a light there. And
Did you define a high-risk patient screening?
actually, I do. I have that up there right now, just by a strange coincidence. There's a couple of different definitions, but the most commonly used one is 30 years of smoking, didn't quit more than 15 years ago, and age 55 to 74. There's another subset that allows screening for 20-year history if there's one other risk factor, like asbestos or radon or chronic lung disease, family history. Then they'll say screen them with a 20-year history.
How do you judge second-hand exposure?
Second-handed smoke, I was surprised that it is not included as a risk factor. That's not to say that there's no increased risk of lung cancer with secondhand smoke, but when they did the analysis, they found that the increased risk was so low that they couldn't move the patients from the middle category to the high category. So secondhand smoke does not, it frightens the patients or the relatives, but unfortunately by itself it's not enough for us to recommend scanning. So we got a B from the Preventive Services Task Force. And some people might think that's a little disappointing, but no one gets A's except pap smear is the only A that they give. B is actually a very good grade. I'm sorry?
That's a preliminary recommendation.
Yeah. It is. It's a draft recommendation of a B. And a part of the issue is that not all trials confirm what the national study here confirmed. There were some trials in Europe that really didn't show the reduction in mortality. And there are other issues I think we've touched on in terms of getting people in to be screened, getting them to come back. High risk, I think we kind of talked about a minute ago. The top group is the one that was used for the NLST, but the Canadian trial, I think they also allowed for that bottom group with one additional risk factor. So this is the kind of the scorecard, just for a frame of reference, because they gave lung cancer screening a grade of B compared to pap smears, but B is actually not a bad grade. It's a tough, the task force is a tough group of people to impress, I guess. So this is kind of a look at what is planned. I think this comes off the hospital's webpage, and this is not up and active yet, but the idea will be to get people to call in if they think they might have a need for screening, and the person who answers the phone is not going to schedule them for a CAT scan. What they're going to do is ask them a list of questions. How old are you? How many years have you been smoking? When did you quit? Do you have a relative with lung cancer? And so on and so on, and see if they meet the criteria. And then if they meet the criteria, explain that we can schedule the scan. And then there are, of course, insurance issues and other things that come up. But the plan is to at least pilot this and see how it goes in the community over a period of time, because lives can be saved. So I think I left some time. I'm done. So questions?
I have a question. So I think there's about 20% of lung cancers are non-smokers, right? Is there any thought as why that occurs? It seems high, but...
Yeah, 20% is about right for lung cancer in non-smokers. Most of those are adenocarcinomas. And of course, that is one of the limitations of screening. Because we're dealing with CAT scans and multiple scans, we really have to limit this to the high-risk population, or it will become a financial... Trying to screen everyone for lung cancer just because no one's risk is zero would just be a financial nightmare and a burden on the system that we can't afford. So we really have to focus on where the yield is highest, and absolutely, there are a lot of people that are going to get lung cancer who would have been turned away for screening. Yes. I'm sorry? You know, it's not your fault, it's my hearing.
Secondhand smoke.
Oh, secondhand smokers do have a little bit of an increased risk, but it's not high enough to put them into the high-risk category. Even if they're like a 20-pack year, that's not considered a risk factor that bumps them up into the screening category. Family history works. I'm sorry?
I have 3 cases of the husband smoked,
And it definitely is an increased risk. I was kind of disappointed, but I guess someone who looks at statistics decided that it doesn't count. I was kind of disappointed because I've also seen cases and you think, well, maybe it's just a coincidence, but it's too many cases of people who say, well, my husband died of lung cancer, he smoked 2 packs a day for 35 years, and then the wife comes in and she's got chronic lung disease, or she's got a pulmonary nodule, and you're thinking, this can't be a coincidence.
And we have to appreciate the government planning the smoking in the restaurants or in the public,
I'm sorry.
Smoking might be residents.
Oh. Well, I think we've done away with that problem. I don't think, I don't, yeah, at least in California. I don't know if that was ever a huge problem, because it's not like you live in the restaurant. It might have been a huge problem for the restaurant staff who work there on 8-hour shifts, and there's a smoky room like a casino in Vegas or something. But I think for the patrons, you're there for such a short period of time, I don't think it's an issue.